Hi, it's great to be here today and welcome to the event. Ben, thanks for such a wonderful introduction. First, I want to introduce the incredible panelists that will be on our session today, which is Breakthrough Therapies for Infection-Associated Chronic Illness. So I have first Dr. John Alcott. He is the director of the Lyme Disease Clinical Research Center at Johns Hopkins University. He's innovating both research and clinical trials on patients with tick-borne and vector-borne illness. Then I have Alfred Garcia-Ramo. He is an associate professor of psychiatry and behavioral sciences, also at Johns Hopkins. And his research examines the effects of psychedelics in humans. He's actually doing a psychedelics trial in patients with post-treatment or chronic Lyme disease. Then I have Marianne Welke-Lesage, who is a long COVID survivor, and she's here to tell her story today of recovery from her condition using psychedelics. And last, I have my collaborator, good friend, David Petrino. He is the Nash Family Director of the Cohen Center for Complex Chronic Illness, which I also work at. And he's also the Director of Innovation and Rehabilitation at Mount Sinai, where he does rapid implementation of new treatments and trials. So I look forward to this group and conversation today. I'm going to start it off, though, with just a quick overview of infection-associated chronic illness so that we all have a basis of the discussion today. So with that, okay. So infection-associated chronic illness, what do we mean? What we mean by this is that every well-studied pathogen, viral, bacterial, or fungal, is associated, if it's studied enough, with a chronic condition or illness in which a subset of people who get that infection do not recover and go on to develop debilitating chronic symptoms that can, in some cases, last a lifetime. Now, these are just some of the pathogens that are associated with infection-associated chronic disease. Of course, long COVID, driven by the SARS-CoV-2 virus, now being a primary example of an infection-associated chronic condition. Up to 6% of Americans, according to the CDC, have long COVID, some form of chronic symptom or debilitating chronic disease after COVID. So studying these chronic consequences of what these pathogens can do, not just what they do in the acute or just regular phase of illness, but what they do in terms of long-term chronic disease is so important to understand right now. To give an example, now, it's important to understand that there are differences in these infection-associated chronic conditions, especially because the pathogens that initiate or drive or contribute to them are different. Some are bacterial, some are viral. They create different proteins. They affect sometimes different body sites or different tissues. But there are some common trends in the way we're able to study them. One of those is that we, for example, can study the very straightforward possibility that in some patients with an infection-associated chronic condition, the pathogen that initiated their symptoms has simply not fully cleared from their body. It instead persists in tissue, often in a low level in what we call a reservoir. So for example, this is a paper that our group at PolyBio, part of a long COVID research consortium, wrote actually on the persistence of SARS-CoV-2 in patients with long COVID. Here, and Steve Deeks, who is part of this team at University of California, San Francisco, recently published this paper in Science Translational Medicine. This is gut tissue taken from a patient with long COVID or after COVID. And you can see SARS-CoV-2 spike protein encoding double-stranded RNA, which is really indicative of active viral replication in this sigmoid gut tissue or intestinal tissue from individuals with long COVID. Really, they found this up to 2 years after initial infection. This is work from Monica Embers, who is also here today. She, in a monkey model, infected monkeys with Borrelia, the Lyme pathogen, and showed that even when they were given a conventional dose of antibiotics, the Borrelia pathogen still persisted in a reservoir in tissue sites again, the lung, the heart. Here is a sample from a patient with myalgic encephalomyelitis or chronic fatigue syndrome, ME/CFS, which is another condition we include in the infection-associated chronic diseases. This is gut tissue from a patient with ME/CFS done by John Chia's lab in California, showing enterovirus VP1 protein in the gut tissue of that patient. So we see this general trend of persistence as just one example of a similarity that we can study in patients with infection-associated chronic illness. But there are many other ones. There's immune activation, clotting, blood vessel problems, microbiome issues happen in these patients, mitochondrial dysfunction occurs, the vagus nerve is often affected, and these are all topics that I'm really excited that you'll hear more about from speakers today. With that, let me hand it over to John, who will follow up. Thank you.
So I'm going to be speaking about Lyme disease, infection-associated chronic illness, and this has been around a long time. Ever since Lyme disease was discovered and initial treatments were started in the early 1980s, it was recognized that people, after treatment, a subset of people didn't get better. And it's had many names, and it's a little confusing because there's been so many names. Through the years, people studied these. Shattuck called them long-term clinical outcomes. Sam Donta called it chronic Lyme disease. More recently, post-treatment Lyme disease syndrome, which is still used in the research setting. And then even more recently, long-haul Lyme. And now we're to infection-associated chronic illness or chronic conditions. They're all the same thing, basically. So if you hear us use one term or another, we're really referring to the same thing with nuances about how they're defined. So what's the same among all these names is it's the same thing. It's the same set of symptoms. So this is we call a butterfly graph. These are people with long Lyme or PTLDS, post-treatment Lyme disease syndrome, looking at specific symptoms, and the severity and number of people with the symptoms is represented by the length of the bar, and the darker color is the severity of the symptoms. This is from the Hopkins Slice study, and we have patients with long Lyme, and we have controls that have never had Lyme disease, and this is prior to COVID, so these are non-COVID patients too. And you see the symptoms in the controls are much milder and fewer than the symptoms in the long Lyme patients. So this shows that people after treatment, remember these people are treated, a subset of people continue to have these persistent symptoms. Interestingly, when COVID came out and these first publications of patient-reported symptoms came out, I looked at their butterfly graph and I said, they stole my figure. It's the same figure, basically. And when you look at the symptoms, it's the same core symptoms: fatigue, brain fog, cognitive symptoms, musculoskeletal pain, sleep difficulties. They're almost superimposable with the exception of respiratory symptoms, which you see in long COVID. But otherwise, this looks very similar to ME/CFS as well. So how do we understand this mixture of severe symptoms that affect multiple symptoms? Of course, the patients are suffering from the condition, but it wasn't really, in my opinion, until we had a case definition that we could start to subgroup patients and really dive into research. So in 2006, there was a case definition put forward for post-treatment Lyme disease syndrome or long Lyme, and it's based on specific things, that the person had Lyme disease, that they were treated, and they had these core symptoms after treatment: fatigue, cognitive, and pain, and that it impacted their function. In other words, these aren't mild symptoms like, run-of-the-mill, regular population-based symptoms. These are severe symptoms that impact people's function and quality of life. And you obviously have to exclude other causes and do a good workup. So when you have case definitions, you can start to study what's going on. And so we've been studying this at Hopkins for over a decade now, and we focused a lot on brain fog and cognitive symptoms. And so these symptoms seem to form subgroups, and one subgroup are the people that have lots of brain fog, fatigue, sleep disruption, anxiety, and depression. Those kind of neurocognitive, neuropsychiatric symptoms are very common, and we started using these case definitions to say, is there really something here? People had poo-pooed these symptoms as not being, quote, real. And so when we really looked at these symptoms and did detailed cognitive testing, we could show that these patients have changes in processing speed and attention and verbal memory. In other words, there is something here. And taking it deeper, we said, well, why might the brain not be working? And we did the first study ever to look at inflammation in the brain in long Lyme disease. And this PET imaging study using a specific tracer for glial inflammation showed that patients with long Lyme disease have inflammation in their brains on these PET imaging. So starting to apply science to what's going on. So I'm going to transition to treatment. How do we find treatments? After all this decades, we still don't really have adequate treatments for long Lyme. There's no FDA-approved treatment. Pharmacologics are used in an off-label use without FDA approval, complementary therapies, similarly, and herbal therapies and devices. So all of these things are out there. This is a picture I took recently in an apothecary from a 1800s pharmacy. And that's what I kind of liken what we're doing right now in long Lyme disease. There's a lot of things on the shelf here. We don't know which ones will last and which ones won't. On the shelf here is mercury and arsenic. Not using those anymore. But also on the shelf here is digoxin, aspirin, and quinine. Actually still use them today. So there probably are things out there now that we will find will work, but there's so much room to add to our armamentarium, and that's what Al's going to be talking about in a minute. Before we go to that, I just want to say patients are often told that it's all in their mind. We're not suggesting that this is a psychosomatic illness by focusing on treatments like psilocybin. It's not a psychosomatic illness. It's not all in the patient's minds. It's actually partially in their brain. Not their mind, but their actual brain. In other words, the organ that sits inside your skull is an organ that's affected by diseases, and we're starting to be able to measure what's going on in the brain using advanced modality like functional MRI. So Sherry Marvel at Hopkins is doing studies now showing that the brains of people with long Lyme have changes in functional MRI that show that Lyme disease affects the brain both physiologically and during memory tasks. So it makes sense to focus therapies on the brain because that's where a lot of the action is going on, and it's real, it's objective, you can measure it. And with that, I'll turn things over to Dr. Garcia.
Great. Thanks very much, John. And I am really fortunate because I'm kind of at the intersection of some really interesting research areas right now. One of which is, looking at some of these infection-associated chronic illnesses, and the other side of that coin is working on psychedelic research. And so, for those of you who don't know, over the past decade, there's really been a resurgence of medical and neuroscientific research looking at psychedelics such as LSD, psilocybin, MDMA, DMT, and so on. And many of these have been focusing on looking at their therapeutic potentials in treating mental health conditions, primarily things like major depression, post-traumatic stress disorder. However, a very interesting outgrowth of research with psychedelics has focused on some of the more physiological types of effects of these drugs, including anti-inflammatory effects, including analgesic effects for helping people with chronic pain-related conditions. And so that really led us to do the type of work that we're doing now, which is a small pilot assessing the therapeutic potential of psilocybin, which is a naturally occurring psychedelic found in about 200 species of mushrooms. And we're using that in combination with psychological support to see if it has any impact on some of these symptoms that John noted that come along with this post-treatment Lyme disease syndrome. So for this study, we designed basically a proof of concept trial where we were able to enroll and treat 20 patients with post-treatment Lyme disease. These were well characterized. Many of these were patients of John Alcott and his colleagues at the Lyme Disease Research Center in Baltimore. And what we did was we gave them an 8-week study intervention where we administered 2 doses of psilocybin, 15 milligrams in week 4 and then 25 milligrams in week 6. Those are moderate and then high dose of the drug. And the 25 milligram in particular has been used for antidepressant treatment. And so what we did, though, is give them those 2 doses of the drug and just follow them up for about 6 months to see how they're doing afterwards. And we really wanted to focus in on some of these symptoms, these core symptoms of post-treatment Lyme disease, as well as looking at whether or not there's any impact on quality of life. So I'm giving you a little bit of a sneak peek right now behind the scenes. We have finished treating all 20 of these patients now, and we should have all of our data by March once we finish all the follow-up visits. But for now, I'm going to show you data from the first 16 individuals who we treated. 56% of these were women, mean age of about 46 years. Most of these people had never used any of these psychedelic drugs in the past. So these are not people who are coming in for drugs. Really, they're trying to find, many of these folks are at their wits' end, trying to find something that's going to help them. And so they're really open to anything that seems reasonable. And so I'm just going to go ahead and cut to the chase here. So this is using what we call the General Symptom Questionnaire 30, which is specifically developed to look at some of these core symptoms are related to these infection-associated chronic illnesses. That includes things like neuropsychiatric, but also pain, fatigue, sleep disturbances, and so forth. And so what we see here is that on average, there's a significant reduction after treatment with 1 dose of psilocybin, and then after the second dose that persists up to about a month post-treatment, that we're having these significant reductions in just their total overall symptom burden. And so this seems like it's been relatively effective, just looking at the whole picture of all of the different symptoms put together. And then when you start to tease apart some of the other subfacets of this, so looking at psychiatric symptoms, including depressed mood and anxiety, there are significant reductions, and that's something that's also persisting out to about a month after treatment with 2 doses. Same goes for pain and fatigue. We have significant reductions in pain and fatigue that are persisting up to about 1 month after treatment. And this is something I don't usually do, but this is actually a really nice email that one of our participants sent me. This lady is a university professor, and so she had really struggled since her diagnosis. She had been having a very hard time doing things like her regular workload, teaching classes, grading papers, and so forth. When she had done the treatment, you'll see that she basically sent me this from her wearable, showing that her daily steps basically doubled after the treatment. So she went from about 3,500 steps on average. That's over the course of many weeks, 22 weeks there. And then as soon as she had started the psilocybin treatment and had her 2 doses, she's averaging about 7,000 steps. So the fatigue, she was saying, is really kind of improved significantly. Now, of course, this is an N of 1, but it's really compelling when you talk to these people and you hear their stories, because when she comes back and says, now I can grade those papers, now I can teach my classes and feel like I have energy, it is really something that makes you think that this could be really helpful for a lot of people. And, to really kind of drive that point home, this is the quality of life assessment that we did. And this doesn't go out just to 1 month. This goes out 3 months after the treatment. So this is not just something that, we're seeing people feel better when they're on the drug, but we're actually seeing people are feeling better for months after we give them the drug, out to 3 months. And so we have a significant improvement in quality of life, where you're starting around 5 on a scale from 0 to 10, and you're really kind of bumping up to about 8 or 9, and you're sticking there for months afterwards. And so, again, this is really indicative that this has some therapeutic potential, and we're really hoping to dig in and do some more research so we can understand the how, and the mechanisms behind this, and including the biology, including the, brain-related signatures that may be changing once we administer these types of treatments. So with that, I'll just go ahead and pass on the microphone here to my next panelist here. So here you go.
Thank you very much, Al.
Thank you.
We're going to switch gears a little bit here from the research and the slides with all this rich information to talk about my personal story with long COVID and the recovery that I experienced with MDMA and psilocybin, and the long-term impacts that has had on my life. My case is documented. There's a paper called Long COVID Symptoms Improved After MDMA and Psilocybin Therapy. It's published in the Journal of Clinical Case Reports. And all of this was made possible by Court Wing at the Psychedelics and Pain Association, which is funded by the Cohen Foundation. And there's also some more information you can find online about it. There was a podcast with the doctors and researchers who documented my case on psychedelics today as well. So my motivation for coming forward and telling my story is about communities and organizations like this that are doing really, really important research in these spaces. My treatment was not done in a clinical or a research context. It was done with an underground therapist. So technically what I did was illegal. So coming to talk about this in a public way, it doesn't come without personal risk, but I'm motivated by the potential of these medicines to help millions of people that are suffering from long COVID and Lyme and all kinds of infection-related chronic illnesses and mental health issues and many things like that. So my COVID story starts in early 2022. My initial COVID infection was really quite typical and normal. It started with sore throat, cough, headache, fever. Within a couple of weeks, the respiratory symptoms seemed to resolve, and I did not expect to have any kind of complications associated with my infection. That turned out not to be the case. After a couple weeks, I experienced a distinct kind of shift in the symptom profile. The respiratory symptoms had improved while I was plagued by really, really intense headaches and pressure in my head. And they were absolutely relentless. They did not respond to any kind of painkillers. And I experienced a lot of the symptoms that these doctors have talked about in terms of cognitive issues, brain fog, difficulty reading and comprehending, difficulty remembering names of people that I knew well, difficulty coming up with words. It was a really difficult and really desperate time for me. To give you some contrast, in my previous life before COVID, I worked in a very demanding job at a university. I had 2 small children. I was doing a PhD on the side, and all of that came to a very abrupt halt. It was a very desperate and devastating time for me, and that's the reason why I decided to turn to an off-label use of psychedelics. There was no treatments available to me. I was on a waiting list for a long COVID clinic in Ottawa. That waiting list was at least 6 months long at the time. Sadly, that long COVID clinic no longer exists. It's no longer funded, which is shocking. But so moving on to the treatment, I worked with an underground therapist. I did some preparation with her. I did a large dose of MDMA and psilocybin at the same time, 100 milligrams of MDMA and 4 grams of psilocybin mushrooms, which is quite a large dose. The experience itself was nothing short of transformational. I put it up there in terms of significance in my life to the birth of my children. It's kind of a demarcation point in my life of before and after. That's all I'll say about the experience itself. But the impacts of that were that I experienced immediate relief. Immediate relief from a lot of things. I'm going to go back up to my motivation for psychedelics for a moment, in that I was experiencing depression and anxiety with my long COVID in a way that I'd never experienced before. I had never been faced with clinical depression and anxiety before. And it was the research so far on the efficacy for psychedelics in depression and anxiety is the reason why I chose to do that. That's what I was seeking relief for. After my experience, I did get immediate and stark results in terms of relief from my anxiety and depression, but I also experienced relief from my entire symptom profile for long COVID. It was the pressure in my head. It was like popping a balloon inside my head. It was just gone. The headaches were relieved. The cognitive symptoms were relieved. It was really nothing short of amazing. It was really not something that I expected at all. it really it changed my life. Like within a week, I was back to my regular exercise routine. I was reading books. I was doing all the things that I was doing before. It was really absolutely amazing. I want to close with that. Psychedelics, to me, they're so much more than medically useful compounds. I think it's really important to acknowledge the spiritual significance of these things. They have long lineages of thousands of years of spiritual significance, and Indigenous peoples have known about the healing power of these forever, basically. I now use psychedelics in a non-medical context and spiritually and for self-development. And it turns out that for me, getting long COVID and my path to recovery turned out to be a gift. I just want to close with how important it is that we recognize the breadth of the uses of psychedelics. They're useful in medicine, but also in many other ways. That's all. Thank you.
Wow. Thank you for sharing that story. That's really powerful. I am just going to click some slides over. There we go. Oh, that slide looks really pretty. I don't think I did that. So I want to sort of close off the session quickly and leave some time for questions from the audience. But I wanted to talk about how at the core, the Cohen Center for Recovery from Complex Chronic Illness, we're thinking about a clinical trial strategy that diverts from what might be the normal sort of drug development or therapeutic development pipeline, because we really do believe that these infection-associated chronic conditions are different. They have been ignored for years, and they have been minimized for years because cures and answers don't come in the same places that, you know, traditional drug companies and drug development strategies have taken medicine. And so we need to think a little bit differently. I put this slide up not so you can all squint at all of the tiny little text. Don't worry about the tiny little text, but look at how complicated that thing is. This was something that Amy and I put together as we were kind of just mapping out the complexity of long COVID, all of the things that can go wrong in the body as a result of a SARS-CoV-2 infection. And there is, as many people have stated, a lot of overlap between what different infections can do and how they might affect, you know, different people differently. And the only thing I want you to take away from looking at something like this is how on earth could one drug fix this? Probably can't, right? Like, it probably can't. And I think that that is the problem, very simply stated, with the current status quo. We're doing these large-scale single drug trials. When you look at what federal funding bodies are funding right now, it's a single drug for POTS. It is a single drug for autoimmune dysfunction. And they're pouring a lot of money into it, you know, $300 million, $400 million for these large-scale monotherapeutic trials. Monotherapeutic trials are really good at making drug companies money for selling one drug. They're not really good for dealing with complexity. And so I think what we need is an alternate strategy to start thinking about these conditions differently and start understanding who can be responsive to certain drugs and why. And so what I'm going to do is just lay out our strategy, you know, and we hope that people will find this strategy interesting and copy it, because I think that what we need to do collectively as a group of people who are sitting on the edge of medicine, we need to be making our voices heard to regulatory agencies and saying, listen, the way that you're validating, you know, single drug cures for complex illness isn't working out. Let's start thinking about doing different things and start doing things differently. And to that, you know, this is my pitch for how we sort of rethink this. So step one should look really familiar. You know, what we want to do are rapid pilot interventional trials of single compounds, but with one simple twist, which is we utilize deep phenotyping techniques to really understand every participant in the trial from an immune standpoint, from a chronic infection standpoint, from a symptom profile standpoint, from an autonomic standpoint, so that we understand who that person is when they're presenting to us in the clinic for the clinical trial. And we take those measures at baseline, the intervention end, and at follow-up. Then, when we have all of that data, we can actually start to look deeply at people who respond to the treatment. So maybe if we're trying, for instance, to pull from one of our clinical trials for long COVID, we're trying out a drug called Truvada, and we see that 20%, 30% of our patients respond really strongly to Truvada. And then when we look at them afterwards, we notice, oh my goodness, your EBV titers were very high at the beginning of the trial, and now your EBV titers are non-existent, and you've experienced improvement. That tells us something. That tells us something really important. Now, we're not going to go and say, hey, let's give Truvada to everyone who has high EBV titers. We still need to experiment on that, which I'll get to. But I also just want to make some time to say, in addition to innovating on how we do things from a sort of a thought leadership process, we also want to innovate on the methodology side. We recently published a paper alongside our wonderful partners, Akiko Osaki and Harlan Krumholz from Yale University. And I just want to really name the work that Yale did here to create a fully decentralized clinical trial where there was one IRB, there were no study sites. People in any contiguous US state could enroll in this trial. Someone would show up to their house, take blood, help them through the questionnaires that they had to fill out to talk about symptoms, and then a medication was delivered to their home. And we were able to recruit 100 patients in record time. We were able to make sure that we were able to recruit at least one patient from every contiguous US state. And it was a really amazing way of getting a clinical trial done that was incredibly inclusive and didn't bias our recruitment pool to just a few people who happened to be near an academic medical center. So once we've figured out who's responding, okay, now let's run a larger scale RCT, a traditional placebo-controlled RCT, but this time we only recruit the people who have high EBV titers. And we should be able to do further evaluation of efficacy to understand, okay, this drug is really good for people who have high EBV titers. Again, is this going to cure all of long COVID? Probably not. Is this going to cure long COVID in people who have high EBV titers? Probably not, but it is going to make them feel a little bit better. So once we have identified 5 or 6 or 7 therapeutics in this way that really, really work, this is when we move into adaptive platform trials of combination therapies. Now, adaptive platform trials are kind of old news in really advanced fields like cancer research, but they are not really being picked up as quickly as they should in other complex chronic conditions. And in my opinion, this is really what we need to get out there into the world. These highly sophisticated trials that allow us to test 5, 6, 7 different protocols and have multiple arms to the trial. So I'm getting to wrap it up here. So I just want to finish by saying here is a whole bunch of trials that we'll be running in 2025 with different drugs and different devices. Extremely excited, and actually thanks to the Cohen Foundation and getting to meet some of the other grantees yesterday, I'm pretty sure we can say that psilocybin will be on the list for 2025 as well, because the results are incredible. And I'll thank everyone and shut up.
So I think we have time for 1 or 2 questions. You want to raise your hand and I will run to you. Still waking up. Oh, here we go.
So for quite a few of these clinical trials, we, as a patient with long COVID and multiple comorbidities now caused by long COVID, I've found that I would sign up for consideration for one trial and find out that one of my comorbidities kicked me out of being qualified for that particular trial. And yet I would not have that comorbidity were it not for the long COVID in the first place. I was in line for the previous test out of Yale. I clicked all the markers, and then I developed breast cancer and had to have a lumpectomy surgery. That kicked me out of qualification. So we've got a real problem when you've got a complex disease that's affecting multiple systems, and yet those comorbidities exclude us from the testing pool. How do you propose dealing with that complexity?
Thanks, panel. That's a really, really good question, and it's a tough one. This is something that we've been really agonizing over in terms of, I think, with certain clinical trials, when you're chasing a very specific target, you want to be as clear as possible with certain inclusion criteria that might introduce noise into your results. When you're pushing. So what we try to do always is have as inclusive as an inclusion criteria as we can. So we're always very mindful of like, okay, how much play do we have here? How much can we be very, very inclusive versus highly restrictive based on the question that we're asking? I think the advice is not to just make things very restrictive just because that doesn't help people, and that doesn't lead to rapid translation either. So I think it has to be case by case. This is a real non-answer, but I really feel where you're coming from. I think it's incredibly important, especially given the multi-system nature of long COVID and how it can affect lots of things. And we also need to tell people that they shouldn't be going crazy with lots of diagnoses on patients. Obviously, there are some diagnoses that are necessary, but people can come to us with 5 different diagnoses that actually could have just been explained by long COVID and left it there. So that's my short answer.
Thank you. We'll go to one more.
Thank you for those wonderful presentations. I really wanted to comment on something that I think we have to keep in mind very, very strongly, because there may be certain types of treatments that may not be curative, but yet we may design studies where we miss what does change and what can also improve quality of life. For example, not to pick on the psilocybin trial, but I didn't hear anything about improvement in cognitive domains, but yet there may have been extraordinary improvement in other domains. And so I think that it's also really important when doing study design to ensure that we are not losing sight of things that may make a difference now, may not be curative, but yet can actually also lead to important improvement. And FDA designs often are really focused on what is your primary outcome. You may not meet that outcome, you may meet something else. I think we really need to keep that in mind to ensure that while we're waiting for really important big answers and curative answers, that we're also ensuring that we're giving people opportunities for treatments that may make a difference even if they're not curative.
Thank you. I think that's an excellent comment to end on. I think it's one thing that we take to heart at the Cohen Foundation. We're looking for stuff that help patients now, while we also invest in things that may be drug development in the future, and also recognizing the last comment I think is really important. One thing we deal a lot with tick-borne disease is that, to my knowledge, there's been no studies that have looked at multiple tick-borne diseases, because typically when you have a second one, you're kicked out of the clinical trial, right? But the problem is clinicians see people with multiple tick-borne diseases. Ticks carry roughly 20 diseases, and so it's very easy to get more than one of them at the same time. So you have this situation where clinicians have to have the answers for their patients, but the scientific community hasn't provided the data to help them. So we're at a little bit of a loss there, and definitely more work to take to heart. Thank you very much, panel.